Good morning, I am Dr. Gayathri from the Department of Pediatrics. And today's topic we are going to discuss is a very common infection that is encountered in children and adults likewise. However, a very frequently communicable waterborne disease, which is called as enteric fever or typhoid fever in children. So enteric fever, also known as typhoid fever, is caused by the bacteria Salmonella enterica typhi and Salmonella paratyphi types A, B, and C. So, enteric fever caused by Salmonella typhi to paratyphi is 10:1, meaning the typhi is more common. And the route of transmission is the fecal-oral route. That is why the infection spreads fastly and rapidly. Incubation period of this disease is 7 to 14 days, 1 to 2 weeks. So, how does this transmit? Fecal-oral route. So, humans are the only reservoirs and the natural host available. So, contamination can be from direct person to person or through contaminated food or water. Okay, so feces or urine from the cases of carriers, either by direct contact by the person who is cleaning or washing or other sibling that goes and happens and touches by mistake and all, can be a problem. Otherwise, even from the water, soil, flies, and fingers. Okay, this can go and contaminate raw cooked food, again enter a new host. So that is also one of the routes of transmission. See, even in water, this bacteria can survive up to 7 days. In ice and ice creams, it can survive up to 30 days. In sewage irrigated soil, 60 days. And on the external surface of a housefly for 20 days. So, you can see by the survival period itself that it is very hard to get rid of or contain this bacterial infection. So we have to be very, very careful since any loop in the chain of spread, a loophole can lead to infections. So we have to know about this infection and how we can treat it, how we can manage it, and how we can prevent. So what happens through the oral fecal route, as we saw there, through ingested food? Okay, this bacteria goes and attaches to the M cells of the gut mucosa and the terminal ileum. Understand? So the antigen presenting cells will be there, containing the lateral surface, where the right cells present. This bacteria goes and attaches there, and then makes some conformational changes, and then goes into the pair patches or the lymphoid patches which are present there. Then it goes and enters into the epithelium and lodges in the mesenteric lymph nodes. Okay, and that is the cause of primary bacteremia. From there, it spreads through the reticular endothelial system to the other organs, such as the liver, spleen, intestine, and the rest of the intestine and all, and spreads entirely to the blood, reaching the secondary bacteremia is when all the systemic symptoms start happening. It is when the person presents with fever, high-grade fever, and vomiting, abdominal pain, and all those things. And it's disseminated to all the other different organs wherever it is supposed to lodge. So, as we discussed here, the terminal ileal enterocytes are there and they have M cells, antigen presenting cells. Okay, so Salmonella goes and attaches and then gets in the Peyer's patches and the resident macrophages. From there, they go through the mesenteric lymph nodes leading to primary bacteremia. Then, through there, they can go through the reticular endothelial system, going into the liver, spleen, gallbladder, and bone marrow, leading to secondary bacteremia, then widespread dissemination to the entire rest of the all the other organs of the body. And the pairs patches get re-exposed to salmonella typhi via the bile. Okay, bile causes intrahepatic circulation going back again. So this is a vicious cycle. So what are the conditions which promote bacterial survival further? So if the gastric pH is more than 1.5, it promotes survival of bacilli in the gut lumen further. H. pylori infections already reduce the gastric pH and enhances the bacilli survival in the gut lumen. Use of antacids and an immunocompromised state. So this goes and infects in all these layers, So what does it do there in the bowel? Inflammation in the deep mucosal layers and underlying lymphoid tissue goes an axial cause an inflammatory response. Payers patches, that is not Peter's patch, sorry, it is Payers patch. Payers patch gets hyperplasia. Hyperplasia is formed. So then there is necrosis and sloughing of the overlying epithelium, full damage, leading to ulcer formation with bleeding. The only thing about these ulcers is they heal without scars or forming any strictures. And then inflammation extending up to the muscular and serosal area of the inflammation goes on leading, and that causes perforation. Then all the lymph nodes and all the reticular endothelial parts, there is hyperemia of the mesenteric lymph nodes, liver, spleen, in areas of focal necrosis. So all these are the internal happenings that are going on. And when you get after the primary bacteremia and then secondary bacteremia comes up, what happens? Systemic symptoms start coming up, isn't it? So what are the systemic features that are seen? High-grade fever, otherwise known as a continuous step-ladder pattern of fever. You can see in this small graph here. Okay, it is a continuous type of fever with day-to-day fluctuations about 1 to 2 degrees Celsius or 1.5 Fahrenheit during 24 hours. Keeps fluctuating like that, but at no time it touches the baseline. And around the third or fourth day, it reaches the peak, even 41 degrees Celsius. Okay, our following effective therapy of the typhoid fever, gradually fever will start rising and coming down. So it is not like tertian of water fever, fever comes up, comes down, comes up, comes down. There is no return to the baseline. So that is why it is called a continuous step ladder type of fever. So that is to do with the fever. Other features include a coated tongue, vomiting, diarrhea, constipation, abdominal pain, anorexia, headache, and even obtundation. Mental status alteration also occurs. These are the symptoms. On signs, what do you see? Even though there is so much of fever, there is a phenomenon seen here which is relative bradycardia. So usually when there is so much of temperature, you see there will be significant tachycardia, isn't it? Here there is a relative bradycardia, which is a very important feature in enteric fever. And then within the first week, you can see small rashes all over the body, which are called as rose spots, and they present mainly on the tongue. Then reticular endothelial system is affected now, so spleen, liver, and all will be enlarged, hepatospleen and megaly. And then even a tympanic abdomen can lead to ascites also. So complications are widespread to all the systems. CNS complications include encephalopathy, beryllium, ataxia, and seizures. Serious complications, endocarditis, myocarditis, and congestive cardiac failure. Respiratory complications, pneumonia, and empyema. Gastrointestinal complications, already we've seen perforation, peritonitis, and even paralytic ileus. Hepatobiliary, cholecystitis, hepatitis, hepatic or a splenic abscess. Genitourinary, urinary tract infection, renal abscesses or prostatitis, and even the bones osteomyelitis and septic arthritis. So you can see after the second wave, there is widespread infection. All systems are affected. So that is why this becomes a very important condition which we have to prevent. So once you have a clinical suspicion of typhoid based on the symptoms and signs, you have to do a few investigations, isn't it? So what do you usually start with? You start with blood investigations, CBC. CBC will show you leukopenia with a relative lymphocytosis. So the total lymphocyte count will be less, but in the lymphocyte count, percentage of neutrophils to lymphocytes, lymphocytosis will be there. Then there is a deranged LFT, that is, the SG PT levels will be, ALT levels will be elevated. LDH will also be elevated. So normally if the ALT to LDH ratio both are elevated and the difference ALT to LDH is more than 9 times, then it is more of a hepatitis. However, if both are elevated but it is less than, LDH is less than 9 times, sorry, ALT is less than 9 times rise in LDH, then it is more of a typhoid hepatitis. Then other cultures, blood culture, stool culture, urine culture, and a bone marrow culture can also be done. Besides this, you have a screening test, isn't it? An agglutination test, a tube test which is called as Vidal test, and a slide test, which is called the Typhi dot test. And monoclonal antibodies are also isolated now. It is a recent advancement in PCR. While this blood culture is usually, when blood culture is positive, we take it as culture positive enteric fever or typhoid fever. The gold standard culture, maximum sensitivity is a bone marrow culture, but it is not feasible in our day-to-day practice, and hence blood culture is the one that is done there usually. So, continuing with the series of investigations which we saw now, a few points about the Vidal test and Typhi dot. So, Vidal test is a quantitative tube test. Okay. So here you have which checks the agglutination in serial dilutions here. So, like depending upon the agglutination here, which occurs in the tube, they are given levels. 1 is to 640, 1 is to 320, 1 is to 160, 1 is to 80, 40, and 20. So, when it is 1 is to 80 and above, or 1 is to 160 and above, it starts becoming positive, and then a strong positive tube test. Here, there is a rapid slide test which is also available, and it shows how the response to each of the antigens is available. O, H, A, H, and also each one shows one color. So that also indicates which one is positive. So looking at the antibody titers here. Antibody titer in the tube test is measured by the effective flocculation and sedimentation. And here it is by this color change. So, most common mnemonic to remember regarding the investigations in typhoid is the word Basu. So, blood culture is positive usually by the first week. So, it can be taken from the blood or any other fluid like ascitic fluid, bone marrow, urine, stool, and all, whatever. So, blood culture is positive during the first week. Antibody titers are significant around the second week. So, if you take it within the first week, you might not get a true positive, or we can get more false positives or false negatives also. Then stool culture by the third week and urine culture by the fourth week. Of course, many of the fever spectrums overlap with each other. So the differential diagnosis which we have to keep in mind are viral fever, obviously. However, look at the pattern of the fever. Investigations will also help us. Malaria. Malaria, how do you differentiate? You have the specific type of fevers, isn't it? For falciparum malariae, vivax malariae and all. You have the tertian fever, quartan fever and all. Here the fever does not touch the baseline typically. And also the other features associated. Malaria will usually have a severe anemia and some you can expect some bleeding somewhere and all. Sometimes some lymphedema is significant and CNS augmentation and all is more common there. Tuberculosis, of course, the initial primary you will have either previous episodes of fever, weight loss, and it will not be as acute as an enteric. Septicemia due to any other cause, obviously, only investigations and cultures can help you there. Brucellosis, again, you have a history of somewhere to do with unpasteurized milk usually. Leptospirosis also. Contaminated water, rat infestation and all will be a trigger usually, and it occurs in outbreaks, and also you can have a small idea there how it will be. Dengue presentation also will be a little different. You will have a febrile period and afebrile period followed by again a febrile period. Infectious mononucleosis with a small prodrome of cough, coryza, conjunctiva, throat infection. You will have all inflamed lymph nodes everywhere, generalized lymphadenopathy. Acute hepatitis, again, it is a fecal-oral route transmissible disease only, but icterus is a little more common there. Again, counts cultures will help us, and the LFTs will help. So coming to the management of enteric fever, of course, everything needs a baseline tender loving care. So adequate rest, hydration, antipyretics, and a soft diet, because already your gut mucosa, everything is inflamed a lot. You do not want to burden it further. So there's a soft diet, and this is a bacterial infection, so you have to give antibiotic treatments. So, and in case of encephalopathy or shock, dexamethasone is advised to be given at 3 mg per kilogram stat dose and 1 mg per kg 4th hourly for 2 days, that is 48 hours. So, as per WHO and Nelson textbook of pediatrics, this is the treatment schedule for typhoid fever. So, the antibiotic of choice is in an uncomplicated typhoid fever, which is maybe the first episode, a young child and all, they are considered to be fully sensitive. The drugs of choice are chloramphenicol and amoxicillin. The dose of chloramphenicol is 50 to 75 mg per kg per day and amoxicillin 75 to 100 mg per kg per day. On an average, usually for all infections and all, when you take pharyngitis, pneumonia and all that, you will prescribe antibiotics for around 1 week. Since typhoid has got a vast incubation period, as we saw that till around 21 days, isn't it, and can lodge some in people, and even asymptomatic carriers are found to be very common. You would have heard the whole story of Typhoid Mary, who was a cook, and everyone in the household started getting symptoms of typhoid, and they couldn't find the source, and finally they found the cook to be the source. She was quarantined for some time, and when she was brought back again after 3 weeks, they found that again clusters of people started getting disease. So again, she was quarantined for years together, and she remained in that place until she died. So you can, so you never know who is the asymptomatic carrier also. So you should always be careful. So and anyway, since it has such a long incubation period, the duration of antibiotics to be given here is for 14 days to make sure also we are trying to cover this carrier, kill the bacteria and prevent them from becoming carriers. So, in case of multi-drug resistant enteric fever, quinolone or Cefixime, fluoroquinolone, ofloxacin. Okay, ciprofloxacin is not given in children frequently. Ofloxacin, so 15 to 20 milligram for 2 weeks. Quinolone resistant azithromycin or ceftriaxone. So oral azithro at 8 to 10 mg per kg per day for 7 days. Azithro alone can be given for 7 days at 10 mg per kg per day. Usually the dose is 10 mg for the first day and 5 mg per kg per day for the remaining 5 days and all. Here it is 10 mg per kg per day for all the days for 7 days. Zone it is IV 75 mg per kg per day for 14 days. In severe typhoid fever, again if it is fully sensitive, you can go for a ofloxacin for 10 days. Multi-drug resistant, again you can still try an fluoroquinolone IV. And quinolone resistant, you have only taxim or zone. This is the antibiotic of choice. In case you are not accessible to the first line of drugs, again you can the second line of drugs here for fully sensitive. We saw there it is chloramphenicol and ampicillin. If you did not have them, you can go for ofloxacin also. And a multi-drug resistant, we saw it is cefixime or a fluoroquinolone. Here, in first line, you can shift it up to azithromycin too. And quinolone resistant also, cefixime usually will take over. And for a severe typhoid, fully sensitive, it is chloramphenicol and amoxicillin as a next choice of drug. Here, that it was oflox in the first line. So whichever you have, these drugs, these 3 or 4 drugs, you can interchange depending on the if you have the antibiotic sensitivity pattern. Otherwise, depending on which episode it is, the age of the child, what clinical presentation, how you feel it to be. Multi-drug resistant, zone or taxin, and quinolone resistant azithromycin usually. Usually azithromycin is given at a dose of 10-20 mg per kg per day only for 7 days. In case of typhoid, also it is not wrong to give it at that dose. So another thing is 2 to 4% of the infected children may experience a relapse also after the initial clinical response to treatment. So relapse rates are also there. Individuals who excrete Salmonella typhi for 3 months or longer after infection are regarded as chronic carriers. The risk for becoming a carrier is low in children and increases with age. So in children, the chance of becoming a carrier is low. We are able to clearly eradicate the infection, but as the age increases, the chance of becoming a chronic carrier is more. Even a chronic urinary carrier state can develop in children with schistosomiasis. So these things are all to be kept in mind when you come across a case and how you want to manage the case. So prevention. So what are the main things preventing? You saw the route of transmission, isn't it? Fecal, orally, how and all it can transmit through flies, through food, through feces, soil. So what and all should you do? Proper sewage sanitation is to be ensured. Chlorination of water tanks in public places and all. So if you are part of government setup or even in an area, when this you have to outbreak occurs, you have to coordinate with the SPM department or community medicine department and ensure all these things are also going on, because it is all interrelated with each other. And obviously the easiest thing you can do is hand washing, especially before and after using the restroom, public places, handling raw food. Okay, when you go to the vegetable market, come back and all, when you handle these tomatoes, etc., make sure better you can sanitize or wash your hands. You never know how we get contaminated. And vaccines are available for typhoid. An oral live vaccine is the typhoid 21A strain. Typhi oral, it is called as. So this oral live vaccine is present like an oral capsule, and it will be taken as 4 doses on every alternate day for a week. And this is usually for children above 6 to 7 years of age, and even for adults before a travel to a place which is at high risk of developing enteric and all in tropical countries, it is better that you can take it and go. And it has got a good efficacy. It has to be repeated every 3 years though. Besides this, you have a VI capsule polysaccharide vaccine, which is given for polysaccharide vaccines usually given for children above 2 years of age, and it has got a 65 to 80% of efficacy, and it is given. It is also to be repeated once in 3 years. Besides this, there is also a capsular conjugated capsular vaccine, typhoid conjugate vaccine, that can be given for children less than 2 years, because once the child starts taking complementary feeding and biting and taking everywhere, depending on the water quality of the place you're taking, any child is susceptible to get typhoid, and children less than 5 years can show more severity also. So less than 2 years, you can give the typhoid conjugate vaccine. It is given as 2 doses. The first dose is between around 6 to 9 months of age, maximum up to 1 year, and the next dose again at 2 years. This is the conjugate vaccine. Okay, this is a single dose 0.5 ml intramuscular. So only this is oral. The others are all intramuscular injections. So the oral live attenuated strains of salmonella type is good efficacy, 67 to 82 for up to 5 years. Capsular polysaccharide for 2 years of age and older, and a booster every 2 years. Protective efficacy is 70 to 80. And conjugate vaccine has a protective efficacy of more than 90% in younger children less than 2 years. So this is how the vaccines are split. So, all in all, we saw what is the etiology, etiopathogenesis of typhoid, and what happens inside the body, and how the clinical features outside, signs to look for, investigations, and the management, antibiotics and all which are used, and some other supporting management, and how we can prevent it too. So, avoid the grip of the typhoid hand by sanitary privacy, vaccination, hand washing. So, the 5 groups of transmissions you can see: food, fluids, fingers, flies, and feces. You remember the 5 F's itself. You have got a very good point, a take-home point. This how and why, how you can prevent, and if it comes, how you can treat. Thank you.